Hello and welcome everyone to tonight's webinar, the first in a series on cardiac care in the ACT. This webinar covers a refresher on cardiac investigations for GPs, and our next webinar on the 23rd of June with Dr. Siang So will be on acute coronary syndrome presentation and post-discharge care. So please remember to register for that one. I am Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kunal Mohiti, the Events Lead at Capital Health Network, and of course our expert speaker, cardiologist, Dr. Sam Kashkovich. First, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So the usual housekeeping spiel, all participants have been muted, and please type any questions you have into the Q&A box on your Zoom window, not the chat box, so the Q&A box. Sam has very generously said that he would answer questions during his presentation and at the finish, so we're allowed to interrupt him. And please feel free to self-report 1.5 hours of educational activities to your CPD home. So now over to our presenter. Our presenter is Dr. Sam Kashkovich. He is an imaging cardiologist who specializes in cardiac CT, coronary CT calcium scoring, and diagnostic and structural interventional echocardiography. Sam is the Director of Cardiology at the North Canberra Hospital, where he performs contrast echoes, strain tests, 3D echoes, transesophageal and exercise and dobutamine stress echocardiography. So very well qualified to talk tonight. And we thank him for taking the time to speak to us. So I'll stop speaking now and hand over to Sam. Thank you very much, Sam.
Thanks, Leonie, for inviting me for talk to you guys about cardiac investigations. So my name is Sam Kashkovich, and I'm pleased to talk to you guys. And my talk is about the cardiac investigations, just basics, what tests we do in cardiology, which tests we need to perform first, and just basically about how we interpret tests in coronary disease and arrhythmia, different types of the cardiac conditions. This is just my for private room. I'm going to briefly talk about the tests we do as routinely any patient comes to you guys, like with the chest pain or any cardiac symptoms, what tests we normally do for them. People will think they have maybe coronary disease, what tests we're doing for them, which is including functional tests and anatomical tests. And I'll briefly talk about the very common scenarios. I'm sure you guys seeing them very commonly in your rooms, like people with the hypertension, what we're looking for if you're asking for echo, people with aortic disease, people with really athletes having engaged in high intensity sports, what we're looking for and how often we need to monitor them. So coming to the routine tests, so the tests we normally do, like ECGs, or any patient comes to you or to us, any cardiac symptoms, there's the first test we do ECG anytime. We get consults, we see patient in ED or room, or I'm sure you guys, if any complaint that tells us it may be cardiac, the first test we go to the ECG. So ECG is very simple test, is always available, but it can give lots of informations. And it can tell you about if it's got ongoing ischemia, if it's acute ischemia, if it's arrhythmia, if it's anything. If it's abnormal, it helps a lot. But if it's completely normal, still we need to more tests to see what's happening. But it's always available. It's a simple test, and I'm sure most people can interpret ECGs, common conditions. Echo, again, is the same as ECG, is always available and is very safe, non-invasive test. And most patients presenting to us with cardiac symptoms, I think that's, again, the test we need to do it because it's a real time. You know what's happening there. Is any serious condition going on? Is anything can be explain patient's symptoms? So is most hospitals and clinics they available echo and is cost effective. Holter monitoring and loop recorder is mainly we keep people coming with the palpitations, or we think about any cardiac arrhythmia or coming with a syncope. We're doing it's we normally have in hospital 24 hours, 48 hours. Unfortunately, we haven't been done in North Canberra for the last 2 years, but that's routinely we do 24, 48 hours. And if we have a patient coming with palpitations, we really don't know what's happening. These days we're using a smartwatch. And loop recorder we only can do if somebody comes with syncope and sounds cardiac syncope, and but still we haven't got any evidence, so we use a loop recorder. And coming to coronary disease, so is biggest challenge in cardiology is we have two types of tests for to find if patient has coronary disease. One is you do function tests, make patient to do exercise or give medication to increase heart rate or contractility and sees any symptoms comes or ECG changes. So you function patient and then you look at the results, which we have different types of functional testing. The simple one is always available, is exercise stress test. We do two types. One is the Bruce protocol with the treadmill. One is the bicycle. But nowadays, because we have a stress echo available, we try to use a stress echo instead of just simple treadmill, because you're adding another image into the stress test, which is increase the accuracy of the test. W-terminus stress echo again is very important test we do for. I'll explain later, but it's mainly for people really cannot exercise. We use that same for myocardial perfusion scan. W-terminus and myocardial perfusion scan not only for coronary, we can use for viability as well as some other condition we can use. Cardiac MRI, unfortunately, we don't have much access to cardiac MRI and is only on private sector. But in Europe and US, they use as a stress CMR sometimes instead of using the stress echo for finding significant coronary disease. For anatomical tests, as you guys know, is we have two tests for is the CT, which always we do with the calcium score, and this is invasive coronary angiogram. Coronary angiogram, because it's invasive and have some complications, we try to avoid. Especially after Scott Hart trial and ischemia trial, given medical management as good as intervention, we try to avoid coronary angiogram as much as we can. But this is the two tests we look at the anatomy of coronary disease. So starting with ECG, this is a patient actually, I was on call last week. So this is a patient who is 68, has no previous cardiac history. He presented with 2 days intermittent chest pain. So he came to emergency and this is his first ECG. So if you look at that, when the patient comes with the chest pain, you always think about, is this acute coronary syndrome or not? So if you look at it's V1, V2, V3, you see some ST elevation is there. And then you look at the infralateral leads, you see the ST depression. So this is tells me it's probably this is a STEMI was missed. So because this is ST elevation in anteroseptal, and then you have reciprocal changes in infralateral leads. And the acute coronary syndrome, they progress very quickly. So this is the second ECG is after 2 hours. So if you see major changes happen. So this patient was transferred to cath lab. He had LAD was occluded, so had a stent. And because he was delayed a few hours in emergency, unfortunately had distal septum was acarnated. So we're hoping next few weeks to get better. So this is one of the example ECG really can help. So this is the first ECG, you see changes there. So you, and then its changes happen after 1 hour. The second ECG is a guy who he came last year to North Canberra. So he's 39 years old with negative troponin chest pain. So he came with the chest pain, but his troponin, his retro was negative, but ECG was very abnormal. Anyone can have a go see what's the think of differentials.
You could type them in the chat box.
Because I think is engaging is better than just keep talking and going ahead. So he's a very young guy. He's chest pain. ECG could be just incidental. So if you see, it's got quite diffuse, like it's not only limited to one territory.
Yeah. We've got some suggestions. We've got pericarditis, and global T-wave inversion, and another pericarditis.
So excellent. So like, I agree. So because the changes are very diffuse. So you see, if you think about coronaries, it normally affect only one territory. Like previous patient was antroceptal and had a so that was limited to LAD territory. But this is looks very diffuse, like you said, all leads have changes. So differential, I agree, could be pericarditis on recovery period because you got elevation, you at the same time you have T inversion. These changes happen with all, so that's one of the differential could be, but the other differential could be hypertrophic cardiomyopathy when you have any type of cardiomyopathy. If you diffuse changes and is not limited to one territory, so cardiomyopathy always is on top on the list. So I agree, this could be pericarditis acute phase, just recovering, and cardiomyopathy. So this guy, his echo was very abnormal, so he had quite thick septum. So we sent for MRI, and it's confirmed there is hypertrophic cardiomyopathy. This is another ECG. His ECG was recorded before surgery, so just 59 came for surgery, and then this is ECG was recorded. So anyone can comment on the ECG? Leon, any?
Yeah, we've got a left ventricular hypertrophy.
Yeah. Can you see my mouse? Yeah.
There's a Wolf Parkinson White.
Perfect. Yeah.
Yeah.
So excellent. So this sinus rhythm, if you look at this, PR interval is very short, and look at the QRS is wider than normal, what we expected, and you have this delta wave. So that's excellent. So that's the Wolff Parkinson White. Yeah. So we don't call Wolff Parkinson White syndrome. We only call changes, because we only call Wolff Parkinson syndrome if patient had a previous event or syncope or tachyarrhythmia, but we called just pre-excitation pattern. This is patient we had again a few weeks ago. It's 83 years old with COPD, presented with dizzy spells. Anyone can comment on this? So 83 with COPD with dizzy spells.
We haven't got any answers yet. I know we've got one. Heart block.
So yeah, it's actually we were initially struggling to see what's happening, because you see P wave there definitely is a sinus, but some of the PR interval is different. But the 83 with COPD always you think about multifocal atrial tachycardia. If you see you got P wave there, but P wave have different shapes. So it's coming from different area in the atrium. So this is a multifocal atrial tachycardia. So you see, ECGs can be very helpful, and most even you guys have in clinic you have ECG show, so it can tell you a lot about what's happening if patient come with the symptoms. But having normal ECG doesn't exclude any conditions. Now, any questions for ECGs?
I was just going to ask a question. So the auto prompts or the auto interpretations, how valid are they?
Something depends on what the most time the correct. So I'm always checking mine in what I have on my room. Is more than probably 80% the accurate. Like, I tell you about what's the axis is, what's the bundle is, what's the PR interval. So in terms of if it's good quality ECG, because sometimes patient is whatever you do, you can get good ECG, keep moving. But if you have a good ECG, normally the interpretation is correct in terms of the intervals, in terms of the bundle branch, or sometimes it can, if you have lots of like people with the Parkinson or people really keep moving, it's very hard. It doesn't give you a correct interpretation. So if no question, I'll go through the echocardiogram.
Yep, there's no questions at the moment.
Okay, yeah.
Yep.
So echo is my area of interest. I love echo. So echo is the most used comprehensive cardiac imaging modality. And it's often first test our choice for assessing cardiac structures and function. It can be performed quickly and with minimal patient inconvenience and risk. It provides immediate clinical relief, because you just patient come to ED, we go to ED, and same time we register got a handheld echo, and it just tell us what's happening. So that's important. So it's very low cost. It's probably is not correct. Sometimes it's cost for patient. So echocardio provides detailed data on the cardiac structures, size, shape, chambers, as well as the function and valves. And it's real time, so you can see what's happening same time you're seeing patients. And you can get immediate non-invasive information from the patient. And its echo is, in most centers, we add to the echo, we do transesophageal echo if they have a proper probe, so have better resolution, especially transesophageal echo for structures which is posterior located, looking at mitral valve, looking at atrium appendage, any valvular disease. If you will look at the thrombus, because the resolution is better than transthoracic, and sometimes it's just transthoracic echo, you can get any images. It's very hard because patient body habitus or patient with advanced COPD is very hard to get good pictures. So with the TOE, you can get quite good pictures, images. And same for the stress echo or dobutamine stress echo, you can on the echocardiogram as a functional test to diagnose a coronary disease. And we have lots of advances in echo now these days. Some of them still is in research centers, but 3D echo we've been using for a long time, especially for valvular dysfunctions, as well as the strain. Myocardial work, again, is another new technology in echo. Again, in some centers, they use the myocardial work, but it's mainly in the research now, but it's going to be in practice, probably clinical practice in the next few years. Contrast echo again is very helpful because sometimes when you do echo, especially you want to look at the wall motion abnormality, especially in patient coming with the STEMI or non-STEMI, they don't have a good picture. So you add contrast to see exactly how the walls coming together. So we use very frequently in hospitals. So the echo is based on the standard physical ultrasound. So the high frequency sounds, which between 1 and 10 megahertz, it's emitted by the transducer. If you see the transducer is here, so it gives 1 to 10 megahertz, goes to the tissue, hit the tissue, and the time between them, it comes back waves to the machine, and the machine produce the images. So then we know what the images are, is the normal or abnormal, then you do measurements. The most common modality we used before and still we're using is the MO. So it's mainly we measure the distance, measure the dimensions and the thickness. Still is very commonly we use in echo. Any echo we do, we use the M modes because it's very accurate and in real time. So while you're doing echo, you can measure your RV size, your wall thickness, your septum, and your LV. And also we can move your cursor on the valve. So you could relate your valve opening, closing with the systole and diastole. So in valvular regurgitations is very important, like with the mitral regurgitation and aortic regurgitation, you use M mode and you see if it's a pansystolic or is a late systolic or early systolic. It helps a lot. So it's MR and also AR. And now the advance is the strain. So the strain is on the left side. If you see what the strain does, it's calculate any movement in any speckles, any part of the ventricle. And we have a strain now in ventricle strain, left ventricle, right ventricle. We have a strain for atrium. And we have 3 types of strain. One is the longitudinal, one is the radial, and one is the circumferential. If you look at the right side, it's a simple calculation. It means you have a 0 length and you have the after movement, so you have L1. So in longitudinal and circumferential, because you the second length is smaller than initial length, you always get negative strain, but is the radial is because it's the heart muscle, it is thickened, so you get positive strain. But with most labs, they're using longitudinal strain as a reference. This is a simple, again, is explained. So what we normally do, we do simple echo, 4-chamber, 2-chamber, we do a long axis, and then most machine, they have just automated one. You just click on the button and it comes. But then you're moving your cursor and adjusting your pictures, and then you give you 2 types. One is the see when do you have maximum systole or diastole, and if it's lined with your time with your ECG or not. Tells you about the cardiomyopathy or thickness. And then you see bullseye. So what they do, it goes to each segment of the heart and do the strain. So we have 17 segments, and which is each segment being supplied by different coronary artery. So strain, when you do a strain, it gives you bullseye. It's give you a strain in each segments. And if any segments is strain reduced, then you know that is something is not normal there, which is more accurate than just visual looking at ejection fraction or wall motion abnormality. And then the other advancement is the myocardial work. So what the myocardial work is getting the afterload, so involving the afterload in your strain. So you calculate your strain and then you times your strain to systolic blood pressure, because the measuring the left ventricle pressure afterload is invasive. So we just, instead of we using systolic blood pressure as afterload. So you're calculating your myocardial work, and there's a few different types of the work you're calculating, which is probably next 5-10 is going to be in routine echo measurements. So you have global work index, you have wasted work, you have efficient work. So you measure different types, and it tells you if it's normal or not. So this is what I explained. So we have different types of the myocardial work. So this is simple. You just times your strain, whatever strain you get, average strain times in your systolic blood pressure, give you myocardial work. And this is the normal range for myocardial work. For the strain, normally is for left ventricular strain is -18 plus -2, but each vendor, each company, they give you Ecolog, GE, they have different normal range for the strain compared to others. So we strain as well as for myocardial work, we're using in a different subgroups like we use for hypertensive heart disease. Sometimes your patient you're saying for assessment. So patient has hypertension for many years, it's probably been poorly controlled. So you want to see how much effect has on the heart. Has patient got any hypertensive heart disease? So you may do normal echo. You may see is the wall thickness is normal, size is normal, aorta is not enlarged, but you call it normal. But when you do a strain or myocardial, where you see it's there's some damage is being done because of the hypertension.
Is this something that GPs request from cardiologists, or is it something that cardiologists will decide to do after they've kind of done a stress echo?
So it depends on who is doing it. So far in hospital, I'm working as well as in Canberra Hospital and my room. So we always tell the sonographer, if patient has really good pictures, you should do a strain and myocardial work. And most of the time they do it, unless something they're doing urgent, they don't have time. Because it's normally if you want to do a strain and myocardial, there's extra probably 5 minutes you need to spend on the echo to do it. So most time we do it, and especially if people with cardio oncology, the cardio oncology we always do a strain unless really pictures very bad, or amyloid, you're looking for amyloid. But for hypertensive heart disease, again, if they have good pictures, we try to do it, and you don't need to request, but they should do it if they have a really good images quality.
Yeah.
So again, for a strain and myocardial work for coronary disease, we very often patient come with the chest pain, troponin is negative. You do normal echo, there's no wall motion. But when you do a strain, actually you see a strain in some territory, strain is low or myocardial. So you know it's probably they have coronary. So then we send for angiogram or CT. Same for any types of cardiomyopathy, the ischemic or non-ischemic hypertrophic strain and myocardial works. And amyloid and cardio-oncology is the two subgroup, which is initially a strain was introduced for them, because amyloid, if you have cardiac amyloid, it gives you a very typical picture of cherry on top. And when you see that, is most likely it's going to be amyloid, even without seeing the bloods or cardiac MRI. Same for cardio-oncology. I'll explain later. Using a strain and myocardial has been helping a lot. So because it's a when patient on the chemo, still his ejection can be normal, but when you do a strain is abnormal. So you put on a treatment to prevent further cardiomyopathy. So this is what you see the normal strain. So you see is the all segment is a red and is all numbers above -18, depends on what's the cutoff is that machine. So if you look at it, -22.9 is average, which is normal. And if you look at the peak systolic, so it's all lines come is in the systole. So this is very normal strain. If you look at this one, this is the patient with LAD infarct, so came with the STEMI, and you see if it is not long, it's not on the systole, so it's very disorganized lung. And if you look at here, this numbers very low in terms of LAD territory. So it's the septum, anteroseptum, and it's the apical infarct. So the strain is very low. So if you do this echo even before angio, you know this LAD's got probably LAD ischemia if your patient comes with a chest pain. So for patient with on chemo, so the cancer treatment-related cardiac dysfunction is very common, and there's lots of research is going on that. So normally for chemo, there's two types of cancer treatment-related cardiac dysfunction. One is the type 1, which is irreversible and is a dose-dependent, but the type 2, which is normally happen with the trastuzumab, is reversible. So normally what we do baseline echo, and we know what's the baseline ejection fraction, a strain, or troponin, we know sometimes change baseline, and then in 3 months time after starting chemo, you assess these three: ejection fraction, strain, as well as the troponin. Sometimes we do. So if it's ejection fraction reduced by 10%, but its actual number less than 53, or you strain reduce more than 8%. So that means that you have cancer-related cardiac dysfunction. So what you do, if its dysfunction is significant, you just stop the chemo and you put on heart failure treatment. But if it's only borderline reduced, you put on beta blocker and ACE inhibitors, and then you recheck again in 3 months' time to see follow-up. That's the routine we do for cardio cancer people on the chemo. And we normally do every 3 months. And when they completed chemo, we do 3 months after completion, and then 6 months, and then we do every year for 5 years. So this is what recommended for ESC to follow with patient with the chemo. So the best way you found with the cardiac MRI, but echo doing 3D, strain, doing the myocardial work, and also tissue Doppler. It's that how we manage the cardio oncology. So this is the one example. This is the patient on the left side. This is the pre-chemo baseline. So you see a strain is completely normal. Average is -26. And on 6 months follow-up, you see ejection is reduced to 50 from 63, which is more than 10%. And this number is less than 53%. So, and then GLS is significantly reduced in septum and anterolateral. So this diagnosed with the cancer-related cardiac dysfunction. So we start on treatment this patient. This is the other group we use strain. So this is a young guy, 20 years old, with it came with the palpitation. So the echo, if you look at the left side echo, you see this is the parasternal lung axis. The down one is the lung axis apical. So you see the septum is very thick. So this is the interventricular septum. And then we do strain, so strain and myocardial work. So this is very abnormal. So this is how it helped in differentiating the underlying condition. And this is the another type of the hypertrophic cardiomyopathy when we do echo, because it's sometimes very hard to see the apex on echo, because normally people with hypertrophic cardiomyopathy get missed when they have only apical or HCM. But when we're using a strain or we're using myocardial, it always is helpful. So you see it's strain is base to mid is normal, but when it comes to the apex, it's completely abnormal. And this tells us something then that you can move your probes to find if it's the hypertrophy. So, but the confirming diagnosis always should be cardiac MRI. So this is the first time they used the strains, was amyloid. So, so the amyloid, when you do echo, it's normally if it's the earliest stage, you may miss because you get just mildly thick septum or wall, and you see atrium slightly maybe enlarged. So the just normal transverse echo may not give you much information, but when you do a strain or myocardial work and you see this pattern, which is the apical not infected, but this base and mid is get affected, so you know this is most likely going to be cardiac amyloid.
Sam, there's just a question, and
Yes.
it's just related to the chemo and the question. Are
Yes.
these changes, EF and strain, reversible after the chemo is finished or partially reversible?
So it depends on, as I said, if it's the type 1, like some of the chemo, they cause permanent damage, irreversible type 1. But like anthracycline is irreversible. So you got a damage, you just get heart failure, have to be on lifelong heart failure treatment. But mostly with the breast cancer, that's the normally reversible. When you stop trastuzumab up, in normally heart function within 6 months goes back to normal. So the contrast is the we use very common in the hospital. We normally don't use in the rooms because you need a line. You need to have because the contrast we use is we call Definity. So Definity had to be kept in the fridge. So and is like powder. So we have a special machine when we're using. We put in the machine, so it's changed to the liquid. And you only can keep for 24 hours. So that isn't we only use in hospitals, but it's very helpful because in US, in 75% of the echo they use the contrast, but unfortunately in Australia we're not using that when we should use, because to see the exactly endocardial definition when we look at the wall motion, most people they don't have good pictures, and we report so it's no overt wall motion element. But when you're using contrast, when you're using Definity, actually you exactly see where is the endocardium moving, so you can report accurately. So it's very helpful, and mainly we're using for when you have LV dysfunction and you're not seeing the wall motion properly. And the other indication we use very common is when we have a thrombus. When we have LV thrombus, we're not sure is it thrombus or is it just color is not getting there, or is it just drop off. So when we give contrast, so you nicely explain there is a thrombus there. So we're using these two types of the people. So any question about the echo?
I think that's it.
Okay, yeah. Now coming with the coronary disease, so how we investigate people with coming with the chest pain. So this is the nice explaining what age when they come in with the chest pain, how is the risk of having actually coronary disease. So if you look at the age, look at the male, female, by increasing age, your chance to be having typical angina is more. So, and is interesting when you use, so this is the color state, which modality they're using. So younger people, when even they come with the typical angina, still risk of having coronary is very, very low. And normally we try just use no test, or we at maximum we use probably just a stress test. And because they're low risk, if you have a CT available, you just do CT and you exclude. But when his age goes up, any typical angina, the risk of coronary is high. So you more towards more functional as well as the invasive test. And there's a definition of the typical angina. So it should be retrosternal, should be exercise induced or stress related, and should relieve by rest or GTN. If you're all three, we call typical or cardiac, and if it's only two of them, we call probably atypical, and only one or none, so you call non-cardiac or non-angina. But this is only on the textbook. So when you see it, you just decide on patient you're seeing. It's very, very commonly we see people with even very atypical pain, and especially with a female, you always have to take any chest pain seriously because they can be very atypical ischemic coronary. And this was just briefly tell how accurate tests are. So, so the stress test, exercise stress test we use very often is the sensitivity is very low, so around 60%. Always I say 60 means if you have very good positive stress, it still can be 40% can be pseudo positive. So, and the best stress test 60% Taylor is probably going to be some significant coronary disease. And is always we think about the patient age and how patient is fit is because you can't put somebody very fit on treadmill for 14, 15 minutes, nothing happen, and you do CT, you say is a very critical lesion is there because they very fit, they always just used to it, so they don't get any symptoms, and even ECG you don't see any changes there. So only just relying on the stress is very hard. So we normally try to do a stress echo or W-vitamin or send for CT if somebody really pain is concerning. The perfusion scan or PET scan, the accuracy is very high, but is normally we don't use for that in Australia. Stress echo is very good, so it's normally is more than 90%. We've done a few study in Flinders, is more than 90%, and is very correlated with the angiogram and CT when you do good stress test, especially when if you have ability to combine your stresses with a strain stress. So if a strain can add even more accuracy. And as I said, CMR, we don't have resources in Australia much, so we don't use for the ischemia, we only use for cardiomyopathy. And CT is, of course, CT is best option if you have available, so you can really see what's happening. So for the treadmill and a stress echo, we normally use Bruce protocol. Bicycle, we don't use much because the Bruce is more physiological. That's exactly what happened. You walk, you run, you get chest pain. The only benefit of bicycle is you can take pictures while patient still is pedaling. But for Bruce protocol, you have to stop patient, have to go to the bed. But I found Bruce is better, so it's more physiological, very close to what normally patient has in daily life. So we have few stages. Each stage is 3 minutes, and each stage is get faster and steeper. So we normally have a table, so each person, male, female, as per age, how many minutes we expect to walk, and heart ratings we measure during the test. So the base for stresses is the cascade ischemia. So this is a cascade. So it's when you have ischemia, you first you have blood flow is be impaired to the muscle, and then you may get so the first thing happen on echo, you get diastolic dysfunction. So if you do diastology when you're doing stress echo, is does get abnormal before even you see regional wall motion, and you see wall motion before any ECG changes, and then chest pain comes the last one. So that is in combining the stress test with the echo is more accurate because you see wall motion. Because patient can do best test, doesn't get to this stage. But if you combine with the images, so you could find the wall motion abnormality, or if you do diastology. And this is for obstructive coronary disease, but you could have non-obstructive people having myanoka or vasospastic angina or non-obstructive ones. So these changes are different. Again, your chest pain may comes before because there's no obstruction there. You may not get any ECG changes or wall motion, but you have a chest pain. So when we're doing treadmill, even ECG still remain normal, or if the echo images show no wall motion, still we take the pain as a serious because it could be just a non-obstructive coronary disease. So we always do another test, either CT or angiogram. So this is a C guideline for when we do a stress test, what we're looking for. So normally when we do, we take 4 images, 4 views. One is the 4-chamber, 2-chamber, past, and we have short axis. Picture is not here, and then each view, sort of 4-chamber, we comparing the pre-test with the post-test as a peak exercise, and then you look at the wall motion abnormality. So because each coronary supply different parts of the wall, LV wall, so we know if you have, for example, if you have, this is the 4-chamber, you get is inferior septum. So if you get hypokinesia here, you know it's the RCA's problem, or you get inferior wall. If you have anterior wall, or you get anterolateral, you know it's LAD. So it tells us wall motion, which artery possibly is got narrowed or got blocked. And we calling them as a, if normal, it means when you rest compared to rest to the peak exercise, if you wall thickness get more than 40% more thicker, you call it normal. If it's less than that, it's a hypo. And sometimes you can have dyskinesia instead of contracting going other way. It means quite significant stenosis there. So this is how we grade the wall motion. So this is what we normally get. So you on your station, you machine go as per protocol. So give you in stages. So this is the get 4-chamber. This is rest and peak exercise. This 2-chamber. So you comparing these two, then you know which area is not coming. So that's how you diagnose the wall motion abnormality on exercise. So, but now in the lab, is any question? So when we do, especially in hospital setting, yeah.
Sam, sorry, there's a question on explaining wall motion again, if that's possible. And there's a couple of questions on CTCAs, but I'll leave them to when you're discussing the CT coronary angiogram. But
yes, sure, yeah. So when we do stress echo, when we finalize, the machine has ability to send to you. It comes as a view, a stress view. So it give you exactly same as this one. So it comes can you see my mouse when I'm moving my mouse or not?
Yes, we can see your mouse.
So this is the 4-chamber, this is rest, and this is after exercise. So what you do, for example, you look at this septum. You look at each segment separate. So look at this one compared to the stress. See how much it gets thicker. If it gets thicker more than this, you call it normal. If it's with the exercise, you get less thickness, then you call it abnormal. And disconnecting means this normally comes towards the LV, but when you exercise, it goes actually outside, so it means disconnected. So how we, by comparing the rest and peak exercise, you know which area is not coming. It's got hypokinesia or akinesia, or sometimes you, after exercise, some part of the wall has not move at all. And the other thing, we look at the stress images, sometimes we call ischemic dilatation of LV. Just LV get just blue, or just get massive LV with the exercise. So that means you have severe triple vessel or left main disease. So normally when we do in a hospital setting, we just not focusing on the on the wall motion. We look at the other things. If with the stress test, if patient go to the APO, like patient was completely fine, and then suddenly after exercise they get very breathless, they get cough, it means they have quite significant LV dysfunction. So that's another point to the test, as if something is serious is going on. Or you briefly get very cold. So this is the you can add to your stress test and make its accuracy more. Even heart rate. If somebody we call heart rate reserve, it means you peak heart rate minus your resting heart rate, how much it increases. If person is not able to increase heart rate before heart rate goes to a certain amount is stop treatment because it's too breathless or pain. That's again is one of the signs that is something serious is going on. So if you have more of this abnormal, so it's a wall motion or got a fluid in lung, or you have pulse is very weak or cold periphery, or heart rate is not increasing, so you know it's something serious. So you're not only relying on your wall motion abnormality. So when you do a stress echo, like I said, a stress echo normally 85 to 90% is accurate. So, but you can call positive while there is no obstruction, or sometimes you can call negative but still is obstruction. As pseudo negative mainly happen with fit people. They do quite good tests, nothing happens. So you have to do something else. But when you call positive, but you do angio, nothing there. So it could be you have abnormal ECG. When you have abnormal ECG, left bundle, when you have, or you have pace leads, it can actually makes your septum very dyskinetic, especially when you exercise in the septum, it just move randomly to left, right. So you may call it dyskinetic because you just worried about it, but could be just pace lead or could be just left bundle. Sometimes when you have blood hypertension, when we do stress test, normal blood pressure response we call up to maximum 210 systolic. It can go like if somebody exercise quite high intensity exercise, stage 3, 4 blood can go up to 210. But if you go above 210, it can actually cause myocardial stunning. So it can make some wall not moving as should be. So we could have wall motion abnormality because of hypertensive response. Also, we can have ST depression because of the hypertension. So we call it positive value, you don't have a stenosis. And the same thing for the microvascular. So if you have myocardial breach, so you see on lots of CT, you see report myocardial breach. It means in normal situation, the coronaries travel over the muscle. But in 20% of people, some part of the like LAD go under the muscle. So we call myocardial bridge, means this muscle is bridging the coronary. So when it's a spasm happen, it can block the coronary for a few seconds, cause chest pain. It's very common, but it can make a test become positive. And only time we intervene for myocardial bridge when patient having ongoing chest pain and is affecting proximal or mid LAD or large RCA. So then have to have an open and bring the artery above the muscle. But it's very rarely we need to intervene. But if you have myocardial bridge, it can make your test positive. Dobutamine stress test we use very often in North Canberra Hospital for, and the protocol is you give dobutamine at 5 mg per kg, 10, 20, 30 every 3 minutes. We use Flinders protocol in North Canberra. We start with a 10 microgram and we go 30 and 40. And for so the dobutamine we use for ischemia. Also we use so you may heard about low flow, low gradient aortic stenosis. Sometimes if you have severe LV dysfunction or moderate LV dysfunction and you have aortic stenosis, because the LV is not strong enough to produce cardiac output, the aortic valve may not open properly and the gradient may not get high. So you don't know is aortic valve stenosis severe or not. So you're using dobutamine. Giving dobutamine to patient, you increase the contractility and then the gradient increases. So we normally use 5 and 10 for aortic stenosis and 10, 30, 40 for ischemia. So when we first do full echo study, and then we start infusion the dobutamine. We monitor blood pressure, heart rate, symptoms. Every 3 months, we increase the dose. And then same as the stress echo, we take picture at rest, low dose, intermediate, and peak dose. And when we finish, we compare these all 4 stages together. So with the again with the same time. So this is the response we see. Either you see a normal response, you get more than 40% the myocardium get thick, or maybe less than 40%. Still get thick, but less than 40 we call hypo. Akinesia is no changes; it just remain unchanged and can be dyskinetic. So, and with dobutamine, we use for reserve contractor. If somebody got severe LV dysfunction, they have coronary. Sometimes surgeon ask us to see if the myocardium is viable or not. Do we need to intervene? So we use dobutamine, see if is the heart function get better with the dobutamine. So sometimes we see biphasic response, means when you give low dose, you slowly get increase the contractility, and then you increasing the dose because ischemia gets severe, so you get less response. So dobutamine we use for people who cannot exercise or patients who have like ECG, we cannot introduce a treadmill, or they have a left bundle, they are on digoxin, they have a pace rhythm, so we use dobutamine stress echo. They have physical limitations, they cannot go on treadmill. For kidney transplant, most time we use the dobutamine to exclude coronaries. For viability, we use as well as for low flow, low gradient aortic stenosis. Want to see if it's a severe, true severe, or pseudo severe AS. So this is how we compare rest, low dose, and peak dose, and then intermediate and peak dose. So we compare all these pictures. And same time, we can add a strain to the dobutamine, which can add. So if you look at the right side, you got some LV dysfunction, but with giving dobutamine, actually you get worse. So that tells you that's called ischemia there. So myocardial perfusion scan exactly is the same as dobutamine. We use for people who cannot do the exercise test, or they have abnormal ECG we cannot interpret, or for viability. Normally, as a cardiologist, because more perfusions can be reported by radiologists, we normally try to not say, but sometimes we don't have any option, we just send. But we use very, very infrequent compared to dobutamine or stress echo. So this is the picture. This is the, in the left side, you see this is the perfusion scan done. So you have resting and stress. You see normally difference between them. So it looks quite similar. So, but because the patient had the symptoms, had a CT, so it's quite significant LAD disease, but perfusions can miss. So it's operator dependent, so they're always reporting is slightly challenging. That is, we're not using, but for viability, we always use. So this is the viability test. So this is a 55 years old patient with severe heart failure and ejection of 30. So this is, if you want to look at the ischemia, so we do resting images, and then after 4 hours, we do redistribution. So you see after 4 hours, the thallium has gone to the loss of the muscle. It means it's viable. And then we exercising, again, is go down. So you see it means is viable and is ischemic. So that's, some cases it's quite good, so it can help. So coming to calcium, I think we have just go quickly through this and go to the question. So calcium score, it's we normally is best to do for people who have intermediate risk. If it's more than 20% the high risk, so you probably don't need to calcium score, just do the angio or do a stress test or put on aspirin statin. If it's less than 10%, you probably shouldn't do it. So people who are in middle group, so it's best to do calcium score. And they should be asymptomatic, because if you have a patient with the symptoms, you should send for either stress or functional test or for CT, CA, and that's the age group. And for some people, they have even low risk. We can consider people having family history of premature coronary disease. It means dad or brother younger than 55, or mom and sister younger than 65. They have coronary disease, so they're premature. So you can use, and patient with diabetes or indigenous, so we can use even a low risk group.
When you say, Sam, when you say risk stratification, you're using the CVD risk calculator?
Yeah. So that's risky. If you calculate risk and risk is that's high, you shouldn't do. If intermediate, yeah, that's yeah. So so we don't recommend for people really low risk or high risk, and people with diabetes over 60, which they had albuminuria, means they have really complication, micro, macro. So you should be do different tests, not just calcium score. And chronic kidney disease, unfortunately, we see even for CTC. I had a gentleman whose cardiologist referred for CTCA. He's a guy who got chronic kidney disease, and I couldn't believe his calcium score was 14,000. I've never seen like that, 14,000. so we should really do. We know it's kidney disease, always going to have very high calcium. So if you have diabetes with a high blood pressure, if you have familial hypercholesterolemia, and your cholesterol is high, this should automatically go on statin, so really it won't add much. Or if you have symptomatic, or you have non-coronary disease. So if your calcium score is 0, so you're low risk, but it's tricky sometimes. I'll show you a case we had a few weeks ago. If you have calcium score 1 in 100, so your risk is low, but some guidelines say if you any calcium score, you really look at other risk factors to treat with the aspirin and statin. But anything above 100, you should be on aspirin and statin. Most guidelines recommend now. So the management, as I said, if your calcium score is more than 100, most guidelines say you should be on aspirin and statin. If it's less than 100, again, you look at other risk factors. Really, if you have few other risk factors, you should be again on statin and aspirin. How long we need to repeat calcium score? So if you have calcium score of 0, is normally if you don't have risk factors, it can be up to 15 years. If you have risk factor diabetes, up to 5 years. Some guidelines say it's 7 years. You shouldn't repeat your calcium scan. But there is a risk of increase by 15% annual if you have calcium score above 100. That is, we say if calcium score above 100, you should just treat without repeating the calcium score. So this is just pretty much say same thing. If you have calcium score 0, you just probably reassure and just lifestyle changes. 100, again, you look at other, but I say some guidelines say if you have other risk factors, you have to really treat. And anything above 100, aspirin and statin being recommended. Same thing. So so this is a very good slide. So say if you have calcium score 0 and calcium score above 0, so it's older age. If you have calcium score even 0, anything above 0, like even 10, 20, so your warranty is very short. So you cannot say, oh, because the calcium score is 0 or 10, risk is very low. So age goes up, so your warranty comes down. So that isn't any calcium score. You have to look at other risk factors. So this is my patient. So this is a guy who, age 52, he was diagnosed with type 2 diabetes, HbA1c of 7.1. And he also is on statin for hypercholesterolemia. Because he was high risk, that's exactly what GP said. I would appreciate it if you can see further investigation. His other was asymptomatic. So this guy came to me. He did 12 minutes on treadmill. Nothing happened. Nothing, no chest pain, no incision. When he went back on the bed to take stress pictures, he had few ectopics happen at the first 2 minutes. And always we say if any ectopics happen in recovery first 2 minutes, it tells us something is not right. So I'll send him, this is the calcium score on the left side. Calcium score was 0. If you look at the right side, this is the LAD. You see, this is a plug there. So this is all positive remote, and this is all plug. So it's 90% is LAD. So calcium score is 0. It's maybe good for somebody, but not for a lot of people with diabetes. So you have to really do CT to make sure you're not missing anything. So this guy, within a week, he went to have a bypass. So this is another images of the CT calcium. So this is, you see, this is CT. If this LAD got quite high risk plaque here. So when we do CT, we're not only looking at it just got narrowing or not. We need to look at see if his plaque is a high risk or it just like calcified long term. So if you look at this one, he has three features of the very high risk. So you have positive remodeling, means the plaque is growing outside the artery, which is being shaded here. He also got very spotted calcium, it's just very small calcium you could see here. And this we call low Huntsville unit, less than 130. So this all tells that is very hard. So this chance this cause STEMI is very, very high. So when we see this plug, we just action as a urgent. So we cannot wait. So this is very high risk. So when you see CT report, make sure you look at see if they have been reported any high risk features. So this is a SCOT heart trial they did for the CT. If you do any patient with the intermediate low risk for CT and you treat, so in 5 years you increase in the, you reduce into cardiovascular mortality. So this is standard care, like you just do the stress test. If it's positive, intervene. If it's negative, no. But this is your all patient goes for CT. So if you have CT for all patient with the chest pain, you reduce mortality by 5 years. Because you go and diagnose with any plaques, you're putting on aspirin, statin, so you will reduce the cardiovascular mortality and cardiac events. So also CT, we don't have in Australia, but there's a few centers in Europe and US. When they do CT, they can actually measure the FFR. So you may see with the angiogram, they do FFR. Fraction of flow reserve means you measure if you have narrowing between 60, 70, you don't know how significant it is, you put a wire, you measure, and if it's less than 0.8, you put a stent. For CT, can do that same thing using some liquid. They use the fluid and they measure the pressure, but we don't have any. But it can be next 5-10 years. We can do, when you do CT, you actually can measure if it's significant to stop sending all them for the angiogram. So CT also not only we diagnose with the coronary, it can diagnose other abnormality. You see, this is the echo. So this is the aorta. Normally the left main comes from here, but this is your left main is coming from the right side. So this is the fluid is going there, and when you do CT, you see the left main coming from the right coronary cup. So this is anomalous coronary artery, and you see this one is all artery coming from one right coronary cup. So this CT can help you in diagnosing even anomalous coronary artery and different other structures. Cardiac MRI, we don't use much, but it's very good on is confirming the diagnosis of hypertrophic cardiomyopathy. This guy is a 58, came with the palpitations, abnormal ECG. You see his quad apex is very thick, and when you do enhancements, you got some scar there. So this is the hypertrophic cardiomyopathy. This is, you see here, this is lots of cavity here. So this is non-compaction. Again, is MRI. So this LV non-compaction again can cause cardiomyopathy and stroke, arrhythmia. This is the very common we see young people come with the chest pain after virus, get myocarditis. Again, MRI is the confirming test we have to do, but unfortunately in Canberra is always in private sector. So for, and we see very often for the neurology, the young people come with a stroke, like cryptogenic stroke younger than 60. We need to look at the cardioembolic source. So we see very often, so this is the patient with LV thrombus, with thrombosis there. We could see very nice, this is the, we call smoke pattern. So again, we can see this all stroke coming from the cardiac. So this is the mechanical valve, you had thrombus on mechanical valve. So actually had similar case 2 weeks ago in North Canberra. So again, so you see, we always do cardioversion. We have to look at the appendage before we cardiovert if they haven't been on anticoagulation. So this is thrombus filling the appendage. So if you cardiovert, so this go all move to the brain. So we have to stop cardioversion here when we see thrombus here in the appendage. The other thing we use for cardiology, if you have patient stroke younger than 60, we always look at the PFO. So this is left atrium, right atrium. This is a PFO. So this is on transesophageal echo. This is not a TT. So, and then how we use the PFO closure device. So we close to reduce risk of stroke. This is the AST. So it's the big hole here between left and right. So this is AST. So this is quite big, so it needs a surgical, not percutaneous. So aorta, you may see your patient done echo, it reported aorta is mildly dilated. It's very important you do yearly imaging because aorta can progress, depends on the blood pressure and other comorbidities. So always, if somebody got dilated aorta, always repeat echo in 1 or 2 years time. So this is the, you can have this one. So this is actually being research done by Prince Charles Hospital in Brisbane because the aortic dimension is changes as per male, female, as per the age, as well as per the height. So how big you are, how tall you are. So this is they done research. This is the normal numbers for the aortic root and ascending aorta. So for acute pericarditis, so always the ECG, but always we do echo because we're looking at pericardial effusion. So the effusion is there, and sometimes it can increase, cause a tamponade. So normally, if you see effusion, we normally repeat echo in a few weeks' time. Make sure the effusion still is low, and make sure they are cautious in to reduce the inflammation. So for hypertension, we always look at the LV thickness, we look at the LV size and the aorta. So these three things on the people with the hypertension, aorta can get dilated, LVH as well as dilated LV. For people with very fit sport people, when they send to us again, it's very important we differentiate what's the normal, what's the abnormal, because they can have a cardiomyopathy, hypertrophic cardiomyopathy, any abnormality. So we need to differentiate in which one is normal, which one is abnormal. Again, using the echo and strain, and then if you don't know, you send for the cardiac MRI. So this is the, we see some changes exactly is the athlete's heart. When you have normal strain, when you have normal diastology, regardless how big is the LV or RV, you see this is a normal. But when you have abnormal diastology or strain, then this is abnormal. But sometimes you have gray zone, you don't know which one. So you have to do cardiac MRI. So this is the pre-competition. So you see his GLS is very low and abnormal. So this is the not athlete's heart. This is the abnormal. This is the cardiomyopathy. Same thing here. If you look at the top, this is completely normal, and this is abnormal. So it's very random. So that tells you that this myocardium is not normal. So for all athletes, we normally do a strain, we try, and if it's something we doubt, we always send for cardiac MRI because it's a risk is they can have arrhythmia during the competition. So in conclusion, we have lots of new advancement in cardiac imaging, and we can diagnose all cardiac condition way before if clinically present. So it's very important if you have any patient with any symptoms, take it serious and send for investigations.
That's great. Thank you, Sam. So we'll start on the questions. So the first question is, can you comment on the relative value of coronary calcium score versus CTCA? I think you've touched on that a bit with the patient with diabetes who had a coronary calcium score of 0, but a very significant stenosis. And the second part of that question is, does the coronary calcium, CTCA, give you info on the artery lumen? And I think you were saying it does to some extent. And how much more radiation? Yes. How much more radiation does it?
So the radiation depends on what machine you use. The machine, if it's a GE machine, if it's the Philips, your radiation is around 1 to 1.5 millisV. So it's very low radiation. In terms of contrast, again, depends on how your heart rate is well under control. We normally give beta blocker 48 hours before the test, so your heart rate around 60. So you don't need to give more radiation because you get good pictures. So radiation is low, and as well as the contrast. Unfortunately, when you have high calcium score, anything above 100, especially if it's dense, is the calcium make shadow. So that makes very hard. You see very often you send patient for CT, the radiologist okay say because of the high calcium interpretation make hard. It's exactly true because calcium makes shadow. So you don't know what shadow is. A shadow is a soft plug sitting behind the calcium. So we always try to, if his calcium score above, especially 400, we do a stress test, and any doubt we send for the angiogram.
Right, that kind of feeds into the next question, which is if the coronary CT angio shows normal arteries, does the patient still need a stress test?
So if the patient have normal CT angiogram and still have a chest pain, so you're looking for the dysfunction, so vasospastic angina, you're looking for, I explained that's the picture that you have different types can cause a chest pain. So in people who have non-obstructive coronary disease, no coronary disease, still they can have a spasm. So in this type of people, you want to correlate your symptoms with the exertion as well as if you can have some ECG changes of wall motion. So if somebody chest pain, it sounds cardiac, we see very often, but CT is normal. We do a stress test, just make sure this is not vasospastic angina. Because if you have chest pain on a treadmill and you have ECG changes, just confirm. But is the only way we can confirm for the vasospastic or dysfunction is we very complex tests they do in cath lab. They give they watch them while they're giving some adenosine to see if it's causing any changes. So you see you give contrast and acetylcholine, and then they can create a spasm, and you see and patient experience same pain. But normally with the stresses, you can suggest is the vasospasm if they have chest pain, some ECG changes. So that reason we do sometime with normal CT, you do stress test.
So I remember about 12 years ago, people were doing this. I'm not sure if I'm pronouncing this, Maybe
Yeah,
stress
the
test.
perfusion scan. Yeah.
That's the one you're talking about.
Yeah.
Yep.
So the perfusion scan, they use different, like they use dipyridamole. If they don't have asthma, they use adenosine, they use thallium. So depends on which center they're using what. But they always, if they combine with this exercise, they're more accurate than only they use the pharmacological.
Right. And that's not something a GP would necessarily order, or to be something that it'd be better to come from a cardiologist.
I think perfusion scan you have to be cardiologist, and because they do only few centers, but I had few GP labs suggested because patient not able to walk, I normally shift to the dobutamine because I like dobutamine. But sometimes we very rarely we see and we send for them, but I'm not sure you guys can straight send for perfusion scan. I don't think they will accept.
Right. Yeah. Then there's a couple of other questions, but I might finish off the CT coronary angiogram and CT calcium scores. Is there an age cutoff for ordering calcium scores, given it takes times for plaques to calcify?
Is a good question and it's very hard to answer because we normally in sub centers they said we don't do CT or calcium score on any above 7 years of age. Well, I have seen done a CT and calcium score in the 90 years old with completely zero. So depends on who is your patient, but most center they suggest instead of doing calcium score or CT on somebody above 70, especially if you have some other risk factors, they don't do it, they refuse to do it. We in North Canberra, we don't have any limitation. And as I said, we have the patient had a chronic kidney disease. He was 80, had a 14,000 calcium. When you have 14,000 calcium, even you don't know what's happening there, how much narrowing you have because it's always the calcium. But most center they don't do above 7 years of age.
Right. Yep. Okay. Just a clarification about your assessment of risk. So the new Heart Foundation risk calculator has classifies people into below 5% risk, which is low risk,
Yes.
5 to 10%, which is intermediate, and above
Yes.
10, which is high risk. And
So this is the 5 years risk, yeah?
yeah. Oh, well,
Yeah.
it's the 5-year risk. So
Yeah.
when you were talking about ordering the coronary calcium score, I think you had slightly different percentages you were talking about.
So
You were talking 10-year risk?
yes. So that's you can use the MESA. MESA is the more accurate one. So the MESA is one that's actually is all investigation and research on the CT and the calcium score is MESA. If you look at MESA is
Could you spell that for us?
MESA, multi-ethnic. Yeah. So this is the American, and they have one European. I think is the HNOK is a Danish, but if you just search MESA, that's more accurate. But it doesn't matter which category you're using. If it's the low risk, depends on what they say, 5% or 10%.
Yeah.
But yeah, Heart Foundation is a 5-10.
Yeah. And then there's a question, in a patient with isolated hypertension diagnosed on a 24-hour blood pressure, would you recommend treating with a routine antihypertensive like an ACE or an ARB, or should the patient have cardiac imaging like an echo?
So if it's blood pressure above 180 over 110, so and is the like average, you won't wait for 3 months,
So
6
I
months
think it
because
was
it's
just an isolated diastolic. So
only
maybe just,
diastolics.
yeah.
How high is the diastolic? So if it's
Yeah.
above 110, you treat, but most time I'll give 3-6 months. But it depends on who you're seeing. If I have patient really fit, they very good diet, and you don't think you're going to with this any change is going to make a difference, you just give a treatment. But if you somebody really is not mobile, can make some changes, lifestyle changes, you give 3 to 6 months before you start treatment. Either systolic or diastolic.
But do they, I think the question is, do they need imaging as well? So do they need an echo as
So
well?
if you think his blood pressure been this sometime, you can, because the difference going to make, if you do echo and you see changes happen, you won't wait for 3 to 6 months. So I suggest if he's available and he can do it, to do it. Because if you see got diastolic hypertension and you got septum is 13 millimeter, you're not going to wait for 6 months. You just straight start on the treatment.
Yep. Thank you. And then the last question we have is, in general practice, should there be screening to pick up AF?
So it's very hard question and it's very good question. So they have been lots of study done, subclinical atrial fibrillation. They're using Holter monitoring, smart watch. They're using devices like people have a pacemaker for some other reasons or defibrillator. And anything more than 5 minutes, they call the subclinical atrial fibrillation. And they monitor them for 5-10 years. The risk of stroke is very, very low. There is a risk there, like compared to people who don't have this subclinical risk, slightly high. But they haven't been in the guidelines, so if you screen people. So the only thing I suggest you do, if people come to, like, we know that about 80 is our age, 50% people have atrial fibrillation, about 70, 30%. If you just do simple ECG, and if you don't find AF, you probably don't need to do Holter unless they have symptoms.
That sounds quite straightforward. Thank you for that. Yeah. So I think we've come to the end of our questions, and I just wanted to thank Sam very much for such a comprehensive explanation of new and old tests and when to order them. It's very useful for GPs and keeping up to date with changes. So thank you so much for that. That was great. And just to let everyone know that the recording will go up on the Capital Health Network YouTube page. And please fill out the evaluation survey and send it back to CHN. And please feel free to record at 1.5 hours to your CPD home. And I think that's it for the night. And so thank you again, Sam. That was great.
No, thanks for your organizing, Leonie. Thanks for that.
No worries. Thanks. Good night, everyone.
Thank you. Thanks.